Howdy, this is Dr. Richard Bernstein of Dr. Bernstein's Diabetes University with our June 2021 episode. Before we begin, I want to remind you that my answers to questions are generic answers. They're intended to educate many of the viewers. It's not usually possible to have the exact right answer for the person who's asking the question, because I've not done a physical exam, I've not gotten a personal medical history, I've not gotten a family history, so I may have my own assumptions about what's wrong or what the problems are, and a totally wrong answer. So check with your physician before you take my advice. Before we answer questions, we have two special subjects today. I've read in some scientific newsletters that non-diabetics who have diabetes in their family are frequently using continuous glucose monitors in order to inform themselves about the effects of foods that they're eating. And I think that this is a brilliant idea. I think it also greatly expands the market for continuous glucose monitors, so that now where diabetics may only be, let's say, 10% of the population, you have the potential diabetics that might be far more numerous as potential users of continuous glucose monitors. So I think this is a very good idea. If you have diabetes in the family, if you're overweight, if you have other medical conditions that may predispose to diabetes, there's a lot of sense in finding out what your blood sugars are running over the course of a day or a week, and what the effects of different foods are upon your blood sugars. Again, on the subject of continuous glucose monitoring, several, or I should say probably many patients, including myself, have sometimes experienced either the ongoing sensor, which right now is on my arm, causing slight pain, or the insertion of the sensor when you pop it through your skin, causing pain. It's not supposed to. If it does cause pain, it's because the sensor has penetrated muscle. And you want the sensor to be in subcutaneous fat, which gives you a better idea of your blood sugar, than in muscle. You don't want it to get into muscle. So for accurate readings, it should be in subcutaneous fat. So you want to find a fatty spot. Well, this week, we found a fatty spot all the way around the back of my arm in one place. I have pretty good muscles, and I don't want to get it in the muscle. And I know it's in the muscle if it hurts. So just a warning, if your sensor hurts, take it out, put a new sensor, and get it in the fatty place. First question. I was just diagnosed with type 1 diabetes. Can I use high-dose vitamin D and your low-carb protocol to reverse my type 1? I doubt it very much. I spoke today to a patient I've been treating, I guess, for about 15 years, who did not have type 1 diabetes. He had mild type 2 diabetes, and I was treating him with insulin. It's a very interesting story, and this question leads into it. He initially had carbohydrate craving, and would, amongst other things, wake up in the middle of the night craving carbohydrates and going for a snack, which of course did not help his blood sugars. And for the carbohydrate cravings, I gave him a GLP-1 agonist. It was either Victoza or Byetta. I usually give those to work at the time when patients get their cravings. So he was probably having a craving after dinner, and I was probably giving him something like Byetta before dinner or maybe at the end of dinner. And it, I guess, helped him also from the late night cravings. And he was on this agonist for many months. Usually I find that they wear off, and we finally stopped it, but he did not regain the cravings. So we reversed the part of his diabetes problem that had to do with carb cravings. And we were also giving him a small dose of insulin in the morning to prevent the dawn phenomenon and to cover his breakfast, which was the main time that his blood sugars went up. They didn't go up very high, but they went up after breakfast. Now now this is maybe 15 years later, and for most of this time, he's been off the GLP-1 agonist, no longer on insulin, and has blood sugars that are non-diabetic all day long, around 83. Of course, he's on a very low-carb diet. So if he were not on the low-carb diet, he'd have high blood sugars. We can't say he's not diabetic. We have not reversed his diabetes, but we have achieved reversal of some things, the craving and also the need for insulin in the morning. Now, as far as this questioner's situation, there's no evidence that vitamin D reverses diabetes, and there's also not been, to my knowledge, studies of high doses of vitamin D. By high doses, I mean doses that would get blood levels higher than the average that you see amongst most people in the USA. I consume vitamin D because I don't get enough sunlight exposure, or my body's not exposed when I am rarely in the sunlight. And I have to take 5,000 IU to get into the normal range, which I maintain mine at around 80 units. I forgot what the units are per deciliter, per picoliter, per liter, whatever it is. But I have to take vitamin D, but it has nothing to do with my diabetes. And I wouldn't take super high doses that get my blood levels higher than the normal range. There may be value to it, but the effects have not been studied, to my knowledge, in human of giving them super high doses. And the low-carb diet will only reverse the diabetes if you're grossly overweight and the low-carb diet causes you to lose weight. Many people become diabetic because of the abdominal fat, called mesenteric fat, that's internal fat around the intestines. So if you have a lot of mesenteric fat and are very insulin resistant, that could be causing your diabetes, but it would not cause type 1 diabetes. So I doubt that you're going to be able to reverse your type 1 diabetes. you could preserve beta cells by keeping blood sugars normal. And we've seen that in a number of my patients where they're newly diagnosed when I see them, and we rapidly normalize their blood sugars. Many of these people can start off on a low dose of insulin and go for many years without increasing their insulin dose, meaning that the diabetes has not progressed. They remain in the honeymoon period. I have a highly skewed basal to bolus ratio. He's taking two kinds of insulins, probably a type 1 diabetic, and he's taking basal insulin to cover the fasting state, which is the long-acting insulin, and bolus insulin, rapid-acting, to cover his meals. I take a half a unit of Lantus every 24 hours and 1 unit of Humalog for every 3 grams of carbohydrate that I eat. I was diagnosed 3.5 years ago, and I'm wondering if this could be a lingering honeymoon phase, or what could cause such a highly skewed ratio between my basal and bolus insulin. I think this fella or woman has made a good guess that he probably is still making insulin. You could check this by measuring his serum C-peptide level. And when he eats a meal, he needs more insulin. So he's making enough insulin to cover his fasting state, but not enough to cover his meals. So he has to inject more insulin for meals. That's very logical. I could be wrong, but it makes sense to me. Now, this doesn't appear to be a question. It appears to be a statement. I don't agree with your approach and would like to hear you respond to my challenge. Everything in life is about balance. I realize that the better I am at creating this harmony, the better my life will be. So when it comes to health, balance is just as crucial, including blood sugar levels. We should be able to enjoy all foods. Well, what sort of balance did our ancestors have who roamed the equator and ate principally wild game? They were not agriculturalists. They didn't plant seeds, and they exclusively ate wild game, and we're their descendants. Agriculture is relatively new to humanity, so a natural balance would be just to eat wild game. We've introduced planting wheat, rice, and other things, and breeding fruit that becomes sweeter and sweeter with each generation. So we've managed to generate foods artificially that make us obese, that raise blood sugar, and that bring about a previously unknown ailment called diabetes. So if you want to have your kind of balance and raise your blood sugars, you also can expect not only to gain weight, but to develop the ultimate consequences of the high blood sugars, which I assume that you've read about, or may even have relatives who have lost their legs or gone blind, etc. And if this is your cup of tea, well, that's your choice. I am a mom of a type 1 diabetic. He was diagnosed at 5 years of age. He is now almost 21. Everything that he knows about managing his disease came from me. I learned the conventional carb counting. Now he is independent. I am having a hard time convincing him to look into low carb. I myself eat a keto carnivore diet. Do you have any suggestions on how I can open up this topic with him? That's a tough problem. If you were his wife, I think it would be a lot easier. As his mother, and he's right a few years, 2 years out of his teens, it becomes more difficult. I could tell him a story. I could tell you a story that you might pass on to him. I have a granddaughter who married a young man who's a type 1 diabetic and had an hemoglobin A1C of 10 when they got married. I gave them a copy of my book, Diabetes Solution, and she worked with him. She read the book cover to cover. Initially, I don't recall whether he read it or just let her give him suggestions. But the two of them together got his A1C down to 5.2. And I just saw them a few days ago, and he looks great. And he's very pleased. They're following the dietary recommendations that I gave, and they're also using the techniques that I teach in the book for how to use insulin. So if you tell him this story, and maybe if you've read the book and you offer to help him, get him to read the book, it's a excuse me. If you help him, or if he's willing to get help from you, and you both read the book, that would be great. But let him know what happened with my granddaughter and her husband. I might also add that I think an A1C of 10 is an average blood sugar of something like 300 milligrams per deciliter, and is almost assuredly a way to go down the tubes from the complications that high blood sugars cause. We have an 8-year-old type 1 diabetic. We're from Israel. We're following your low-carb diet plan, and the results are great. Our endo has prescribed us with 2 medications. Panogam, to be taken at small dosage prior to each meal. And I don't know what Panogam is. I think it's also called pantenic acid. And Januvia. Now, Januvia is sold for the treatment of type 2 diabetes. I had tried it on some of my patients when it first came out. It had almost no effect upon their blood sugars, was not as potent at inhibiting overeating as was the GLP-1 agonists. So I just don't know the purpose. I also recall that there was an unpleasant side effect, potential side effect, I should say unfortunate potential side effect profile from Januvia. So I have no idea why they would give it to a young type 1 diabetic. I don't know what the purpose would be. If you've seen any benefit, fine. But I would certainly suggest that you read my book and that you follow not only the low carb guidelines, but also the guidelines for how to use insulin, adjust insulin doses, dilute insulin, etc. You might also ask your doctor what has been his experience with prescribing this for type 1 diabetics. Has he prescribed it before? And what results did he see? What adverse effects did he see? And what was it that was improved? Did they require less insulin? Did their blood sugars level off better? Inquire, see what it may be that he has no experience with this, that he's using it on type 2 diabetics and probably hasn't seen much results even with them. But ask him. I'm a type 1 diabetic and I follow your book and other recommendations. My question is, following a low carb diet, do you count total carbs or just net carbs for insulin boluses? Well, in the USA, there's no Food and Drug Administration definition for net carbs. Net carbs was created by food manufacturers to make people think that their product had little or no carbohydrate. Typically, what they would do is subtract the amount of fiber from the total carbohydrates and call that net carbs. And I remember many years ago, I was giving a lecture to the American College of Bariatric Physicians in Louisiana, New Orleans. And I arrived several hours before my talk. There was an exhibition of exhibitors, most of whom were selling protein bars. And I had my camera with me. Anyone going to New Orleans wants to take pictures. So in those days, it was a film camera, and I had several rolls of film. And I was going to wander around New Orleans and do a lot of walking in order to take pictures. And I figured my blood sugar is going to be going down. I should have a good supply of protein on board to cover the blood sugar drops. And I went out and walked for 3 hours. And I got 2 free protein bars. And 3 hours of walking. I come back to the exhibition hall, check my blood sugar, and it's gone up from around 80 to 350. So there are many supposed low carbohydrate products that have almost zero net carbs, but the real carbs are very high. So I would say ignore the net carbs. They're a phony creation. Next question, is an A1C of 6.2 good enough? 6.2% good enough? Well, good enough for whom? There are thousands, if not millions, of people who claim to be authorities on diabetes. For the American Diabetes Association, it's probably too low. For me, it's an average blood sugar of about 145 milligram per deciliter, which is almost double normal. So I certainly would not want a 6.2% for myself. What you want for yourself is up to you. There are probably many non-diabetic people in the USA and perhaps worldwide who are overeaters or carbohydrate cravers who have A1Cs of 6.2, even though they don't have diabetes. They're just overwhelming their ability to make insulin. I'm a type 1 diabetic since the start of 2020. My A1C is constant at 4.8, and I follow your advice from your book and seminars. Lately, I've had daily muscle twitches in the legs and occasional calf cramps. Do you think it might be a problem with my minerals, and what tests should I do? Well, all I can think of are probably the two most common causes of leg cramps in the general population. I don't know about muscle twitches, but I know that dehydration can be a major cause of muscle cramps, and the use of statins can is a common cause of muscle cramps and also possibly twitches. So I'd certainly look at what medications and what supplements you're taking, because those are both things that could be causative, but I'd certainly look at how much water you're consuming. You could ask your doctor how many quarts of water a day you should be drinking for your body weight, for your amount of exercise, and for your climate. And it could be that you're just not drinking enough fluid. And it's not just water. You could have diet soda, you could have iced tea or whatever. There are plenty of non-caloric fluids that can serve the same purpose as water. And if you don't find that the cause of your muscle problems, you probably should consult a neurologist. Well, here's a real long question. I eat the same 3 low-carb, high-protein meals every day, each about 5 to 6 hours apart. I am a college student. I am currently living with my parents who are non-diabetic. They eat plenty of high-carbohydrate foods, so I normally eat my meals alone to prevent temptation. This is a sad situation. One of my earliest patients was in the same situation. I find this all to be especially difficult in the holiday season when I am pressured to eat with my family and enjoy carbohydrates. How have you personally handled pressure from family or close friends, both every day and at special occasions? Thanksgiving dinner, for example. Well, I haven't encountered the problem. When I lived with my parents, everyone was eating high carbohydrate diets, and that was recommended for me. When I finally had a family of my own, we were still initially on high carb diets until I discovered blood sugar self-monitoring and saw what they were doing. And we immediately switched my kids to low carb, so in the hopes that they wouldn't become diabetic. And they're still following, they're now older than I am, and they're still following low carb diets. They're no longer kids. And what I don't know how to cope with parents that are so inconsiderate of their offspring. I don't have an answer, but we have other viewers who may be smarter than I am and may have some ideas. So if you out there have some ideas for what this college student can do, aside from getting married, well, maybe getting married is the way to go. But don't make mistakes. You have to marry someone that you love. So if you have any suggestions out there that we can pass on, please let us know. Can you please explain the concept of fat adaptation? What does it mean to be fat adapted? I presume this means that the body is burning fat for fuel in a large proportion to glucose. The only time I've heard a term like that was in the medical literature, pointing out that in cases of famine and starvation, ordinarily the brain depends upon glucose for energy and uses a fair amount of glucose. In fact, we now know that insulin actually gets into the brain to facilitate the utilization of glucose. But if you're starving, the body metabolizes fat, produces ketones, and the brain can live off of ketones. And it takes I understand from the scientific literature that it takes a couple of days for the brain to adapt to the exclusive use of ketones for its energy instead of glucose. So maybe that is where the term fat adaptation has been used. Could be other uses for it, but I have not encountered them. I am 65-year-old male, type 2 diabetic since 1996. I recently did a blood test and my cholesterol was elevated. Should I be concerned about the total cholesterol level and start doing what the doctor said and take statins to bring down my total cholesterol? Well, I guess I have to reiterate what I've been saying for years. It's now been known for quite a few years that cholesterol is not a cardiac risk factor. In fact, in elderly women, the cardiac risk goes down with higher cholesterol levels. I think that the lowest cardiac risk in one study was something like 217 milligrams per deciliter. If you are interested in blood predictors of heart disease and cerebrovascular disease, look at the inflammatory markers, things like C-reactive protein, fibrinogen. We also find that triglyceride is a predictor, and this person has indicated that his HDL is on the high side and his triglycerides on the low side. So HDL is a good inverse marker of cardiac risk. And I've given in my prior videos many of the potential blood markers of cardiac risk. and you could look at those. Now, it does happen that in addition to lowering LDL and possibly lowering total cholesterol, the statins are also anti-inflammatory. But there are many other agents besides statins that may not have the same adverse effects that are also anti-inflammatory. So it's a very complicated situation, and looking at total cholesterol is looking in the wrong direction. In fact, it's called the cholesterol myth. We are strictly following your method but our 12-year-old is now going through growth spurts, which make type 1 diabetes management difficult at times. What is best practices you could share for teens going through this? Well, I'm going through this with 2 teens right now, and it is indeed a real problem. And fortunately, thanks to the blood sugar improvement we were able to generate, both of these teens are going to be taller than their parents. They're growing nicely. And one of them is, I think, his father's height, and I think he's only 13 years old. But the growth hormone can raise blood sugar. And you don't know what day or what time of day you're going to be making growth hormone. Usually, your growth hormone peaks in the middle of the night, maybe about 3 hours after you fall asleep, and may have several spikes during the night. And this can, and it can also continue for several days. So we see with these teenagers a situation where they may have normal blood sugars for a week and then all of a sudden have high blood sugars for 2 days and then back to normal, or they may have high blood sugars for 10 days and then back to normal for only 2 days, or back to normal for 10 days and high for 2 days. It's all arbitrary. We don't know when they're going to be making growth hormone. So they get hit out of the blue with a high blood sugar. Well, at first, I would tell the parents, as soon as the blood sugar goes up, raise their basal insulin. But we don't know when the growth hormone is going to stop. So what happens is the growth hormone excess stops, and they now running too low. Finally, I found one solution with Afrezza, which is an inhaled insulin that works very rapidly. The trouble is that the doses are much too high for kids. And what one of the parents is doing, one of the pairs of parents, is using a milligram scale to weigh out doses of Afrezza that are 1/8 the smallest dose that you could buy on the market. So the manufacturer sells a 4-unit dose. We're giving an eighth of that, or half-unit doses, which she's inhaling, and we're chasing the high blood sugars with something that wears off rapidly. So every 2 hours, they're able to give another puff. Now, why would you want to be so fast? Well, first of all, you want to bring the blood sugar down rapidly, but if more growth hormone is coming aboard, the blood sugars are going to go up again. So during this growth hormone spurt period, could be a couple of days, you want to get the blood sugars down and keep them down. So it happens that for this one kid, a half unit of Afrezza lowers her blood sugar by 50, and her target for her age is 70. So when she's 120 or higher, she uses the Afrezza. If she goes up not that high, we use a different rapid-acting insulin where we can't give the shots more often than every 5 hours. So here we are chasing with Afrezza. In addition, we find out that for these kids, metformin actually works to help them go less high when they have a growth hormone peak. So these kids are getting full adult doses of metformin, usually the slow acting, and we usually give 500 milligrams, 2 of them in the morning and 2 of them at bedtime. Now, when using metformin, you have to be extremely careful because it can cause diarrhea and other abdominal discomfort. So we initially, when we start it, we give it at the end of a meal, less likely to cause diarrhea when given at the end of a meal, less likely to cause other abdominal discomfort when given then. And we give the smallest dose, 500 milligram, and we don't raise the dose until we find that there are no side effects. Now, what if the patient gets loose stools or diarrhea at the start, or it might take a week? Usually it goes away within a month. If it's very severe, we would reluctantly terminate the metformin. If it lasts more than a month, we'd probably terminate the metformin. Fortunately, in these 2 cases, the kids remain on the metformin, and their spikes from the growth hormone are not as great as they used to be. So it's a tough game. There's one other thing that I am going to try. I haven't started it yet because the patient is in Bermuda and can't get the product there, and that is an SGL2 antagonist. Why would I even think of that for a type 1 child when it's meant for type 2 adults? It lowers the renal threshold for glucose and causes you to rapidly pee out glucose when your blood sugar is above that threshold. So it's a way of semi-automatically lowering blood sugar only when it gets high. We're going to experiment with it. It may not work. It may cause, and you have to drink a lot of fluid. And if this young lady is reluctant to drink a lot of fluid, but willing to have her monitor her fluid intake, which is another chore for the mother. So this is a very tough problem. We want to preserve the beta cell survival of these kids, and we know that glucose is toxic to beta cells. We don't want to cause beta cell burnout, so we want to get blood sugars as normal as possible, and that's why I'm grabbing at all these options in an effort to keep blood sugars as normal as possible in spite of the growth hormone spurts. My 13-year-old son has type 1 diabetes. We feed him low carb, but at night his numbers increase about 3 hours after a meal from the protein. Our diabetes team will not allow regular insulin as they don't know how to support it. And he is on Humalog and Lantus. And of course, the Humalog is a very fast-acting insulin meant to cover high carbohydrate diets without protein. And here we're on low carbohydrate, high protein. We need a slower acting insulin, which would be regular insulin. How do I deal with the highs from the protein? How much Humalog should I give him? Seems like no one is able to help. They will only help with high carb questions. First of all, I'd advise you to read my book, Diabetes Solution. Just by reading it, you may learn enough that you could figure out some tricks. For example, one trick might be to give 2 doses of Humalog, 1 dose at the start of a meal or a little before the start, and a second dose maybe 2 hours after the meal. You might need diluted Humalog, by the way, because it's much too potent for small people. Another option is to find a kindly pediatrician who would be willing to write prescriptions for you, and you decide what insulin doses to take and when and so on. But you'd certainly have to read my book a few times first so that you really get to know how to adjust insulin doses and food doses. What's the difference between your low-carb diet and other low-carb diets, commonly known as ketogenic diets? Well, there are many ketogenic diets, and what many, but maybe not all of them, have in common is that they're invented by people with beards. And as you can see, I don't have a beard, so that's probably at least one difference between the diets. What other differences there are, I just don't know. There are so many of them. Many of them are crackpot. I just can't comment. But if there's a beard, get suspicious. I've had type 1 diabetes for 14 years, and your book, Diabetes Solution, has truly been a godsend. In Chapter 9, you say that phosphate, a byproduct of protein digestion, requires calcium in order to be eliminated from the body. About 1 gram of calcium for every 10 ounces of protein foods. When you say 10 ounces of protein foods, do you mean that for every 60 grams of protein I consume from any food, such as meat, cheese, nuts, vegetables, etc., I need 1 gram of calcium? Or is phosphate only a byproduct of protein from animal sources? Protein is protein. Proteins are chains of amino acids. You could get protein from many different kinds of foods. When I say, so I would say that you figure out the total protein you get from all foods. A1C of 6.6%. I'm on a low-carb diet, but I'd love to improve it once I get your book. My question, can I smoke marijuana? Well, If you know how to light a match, you probably can smoke marijuana, but I wouldn't recommend it. I don't think it's a very good idea. There are many adverse consequences of smoking marijuana, and I'm not just talking about becoming addicted to more potent drugs. I'm talking about the adverse effects upon health, including the lungs. So I'd advise you, even if you know how to light a match, not to do it. I am following your plan 100%. My last A1C was 4.8%. I was able to reverse mild diabetic kidney disease with your plan. I take angiotensin receptor blockers for high blood pressure. Is there a possibility that if I keep improving, I can my blood sugars, I can fully reverse high blood pressure? Well, if you're overweight, if the reason for your high blood pressure and your high blood sugars, prior high blood sugars, relates to being overweight, you can lower your blood pressure just by losing weight. Can just normal blood sugars, if your weight is already normal, can just normal blood sugars reduce high blood pressure, which means improving the flexibility of your vasculature? I just don't know. I've had low blood pressure all my life. However, I might as well mention one thing that might encourage you somewhat. You may or may not have heard of Munkeberg's atherosclerosis, which is a calcification of the smooth muscle that surrounds blood vessels and is one of the causes of blood vessel stiffening. It's very easy to measure with an ultrasonic blood pressure device or with an oscillometer. And in 1983, the guy who became my chief of the peripheral vascular disease clinic that I subsequently became the director of, did oscillometric readings on my legs and found that I had severe Munkeberg's atherosclerosis. Normal readings in the legs are 4 to 11 in the calf and half of that in the ankle. And I had something like 19 in one leg, 23 in the other, one calf, 23 in the other, and something like 13 in my ankles. So everything was very high. And we did oscillometry on me about 2 months ago in my office, just out of curiosity. And whammo, I had 6 in the calves and 3s in the ankles, exactly normal readings. So that Munkeberg's reversed, and that was after many years. 1983 to 2021 is almost 40 years. Will that apply to your hypertension? I don't know. I am on an alpha blocker, doxazosin, 1.5 milligrams once at night, and it helped bring my A1C from 6.6 over 18 months to 5.4. Well, I don't know how an alpha blocker can do that. Alpha blockers um, block the receptors for epinephrine and norepinephrine, so they could lower blood pressure. They can also serve as a smooth muscle relaxant. So sometimes they're used for people who have difficulty urinating. Um, so I don't know how it would lower his A1C. Um, it would be interesting if someone did a study on alpha blockers to see if that really happens. Could be that he just started eating less carbohydrate. It also greatly reduced my LDL cholesterol, which again is hard to believe. My concern is that action of doxazosin may be to increase the secretion of insulin like a sulfonylurea and damage the beta cells in the long run and increase the risk of cardiovascular disease. I also take slow-release metformin, 500 milligrams twice a day. Any comments or concerns about doxazosin? Well, I don't have any concerns. I guess it's controlling your blood pressure, sometimes used to control blood pressure. I have no idea whether this increases insulin secretion. I doubt that it does. So I'd suggest you read my book, and you might be able to get your A1C that is already approaching normal down a little bit more. Your recommendation of healthy protein foods, some veggies, sensible insulin dosing, and normal blood sugars seems to be at odds with the authorities who are pushing large amounts of carbohydrate and getting very high blood sugars and double diabetes. By the way, double diabetes is taking type 1 diabetics, usually young people, feeding them a lot of carb, a lot of insulin, and making them fat, and they become insulin resistant and therefore are considered to have type 1 and type 2 diabetes because of the insulin resistance. Anyway, what do you make of this crazy situation? It must drive you crazy. Well, I'm happy to be alive. Um, uh, I went into medicine only out of obligation because I had discovered a way that I could survive. And although I'm frustrated by not achieving as much as I sought to achieve in the way of spreading the word, at least we've hit many thousands of people. But I'm happy to be alive. And I'd like to be around a good while longer. Still have a lot to do. In your book, you have a table which shows how much glucose is required to raise blood sugars for a given body weight. Where does this table come from? Very good question. Way back with my first book, Diabetes, the Glucograph Method, I looked up somewhere. We didn't have the internet, so I had to go to the library. I probably went to a medical library and looked up how much blood was in the bodies of people of different weights. So let's take an example. Let's say that it said for a person of a certain weight, he had 10 liters of blood. Well, 10 liters is 100 deciliters. And 1 gram of glucose is 1,000 milligrams. So if we want to put 1 gram of glucose 1,000 milligrams, into 100 deciliters. We have 1,000 divided by 100. We get 10 milligrams per deciliter. So for this person who has 10 liters of blood, 1 gram of glucose would raise him by 10 milligrams per deciliter. That's what I did. And I used the table that I got in a medical library. Now, in my book, I say this is approximate. It might not be exactly right for you, but you start here and see what happens to your blood sugars and make a correction. Let's say that 1 gram raises you 12. Okay, you were close enough. You got to 10. Now change it to 12. Thanks for watching. Our next teleseminar will be Wednesday, July 28th, 2021. We'll see you then. Thank you.